Acute abdomen, काय घेऊया? Acute abdomen, differential. It will be. I don't think acute abdomen will be asked as a question, but in Viva or maybe for your practice, it will be more important. So, acute abdomen or a differential diagnosis of the acute abdomen. Very commonly, patient can come to you with acute pain in the abdomen, and we will have to make a what exactly can be the diagnosis. Diagnosis depends upon what? The quadrant that is getting involved and the associated complaints. So we are going to be discussing about all the differential diagnosis depending upon the quadrant that is getting involved, and there I can say overview about the management of the acute abdomen. What is the regions of the abdomen and quadrants of the abdomen? Are the different 9 regions? 9 regions, 4 quadrants, acute abdomen. So any condition that is giving rise to acute pain in the abdomen can be the condition. There are various differential diagnoses. Like for example, what is the etiology? Now etiology depends upon which exactly is the region, or I can say quadrant. Now we're going to differentiate upon the regions. Because quadrant we have only 4: right upper, right lower, left lower. But we have the 9 regions. Now here we have lines. Now we have 2 horizontal lines. We have the upper horizontal line passing through the lower edge of the ribs, or I can say this is also on a transpyloric plane, which is passing from at the level of pyloric sphincter. And we also have this is what is called transpyloric plane, and this is called the transtubercular plane. Usually it is passing through L3 vertebra, or I can say the iliac crest, the upper edge of the iliac crest. And we have 2 vertical lines. And vertical lines are passing through mid-clavicular line to mid-inguinal point. The differential diagnosis depends upon where exactly is the pain. Let's say he थोड़ा खालून काढूया म्हणजे थोडा आयडिया येईल आपल्याला. So these 9 regions have got names. This is called the right hypochondrium. We have left hypochondrium. Epigastric. This is lumbar. Right lumbar and the left lumbar. This is umbilical. Let me also draw this थोड़ा सा ऊपर. This is right and left iliac fossa. And this is an hypogastric. So these are the 9 regions of the abdomen. So whenever patient comes to you with pain in the abdomen, we try to figure out where exactly is the pain. That is what we always ask the patient, that if you want to pinpoint where exactly the pain, where will you pinpoint? And say here, because different regions has got different organs. Not even different organs, but different regions also has got a referred pain that is coming from some other organ. So depending upon the localization of the pain, let's say for example, the patient has got more symptoms or more pain, which is I'm not talking about chronic abdomen, an acute abdomen. So we're going to be discussing the differential diagnosis of the acute abdomen pain along with the associated features, along with the management here itself, so that we can understand, and also the investigation. So basic. So let's say patient has got an acute pain in the right hypochondrium. The right hypochondrium, what is the organ we have? We have liver. So what can be the causes in which patient is going to have an acute pain in the right hypochondrium? I can say, if it is dull aching pain, if it is a sharp pain. What is dull aching pain in the right hypochondrium? Dull aching pain, right hypochondrium. Acute is because of hepatitis. It is not sharp pain, it isn't dull aching pain. Because of hepatomegaly. Because of hepatomegaly. Does the liver, is the liver pain sensitive? No, organs are not pain, but the capsule is pain sensitive. Yes, that is what the pain is, because of the capsule is getting stretched or the peritoneum is getting stretched. The sharp shooting pain at the right hypochondrium is because of the gallbladder origin. Because gallbladder has got smooth muscles which can go into pain. Gallbladder has got smooth muscle. Like for example, we have cholecystitis. We also have stones, what is that? Cholelithiasis. As cholelithiasis is not going to give rise to pain unless it is going into cholecystitis. Gallstones are not painful. Gallstones can be silently sitting in the gallbladder. Silently. It can also be cholangitis, right? Inflammation of the vessels of the gallbladder, cholangitis. Yes. Choledocholithiasis can give rise to pain. What is choledocholithiasis? Cholecysthiasis will not give rise to any acute pain unless it is cholecystitis, because cholecystitis is the most common cause of gallstone. What is gallstone? Cholangitis is an inflammation of the vessels of the or capillaries of the gallbladder. Choledocholithiasis is what? Chole is this is the stone which is there in the common bile duct, CBD. This gives rise to spasmodic pain. Which one? Yeah, choledoco wala. Along with that, what will the features? Now let's say, if it is dull aching pain, it is an hepatitis. Patient will be having viral hepatitis. So watch for what is the investigation we'll ask for? Liver function test. Viral hepatitis per se doesn't require any treatment. All of us know it requires 6 weeks diet therapy, rest, and all those things. And patient becomes all right most of the times. To rule out any inflammatory pain or sharp shooting pain, we'll have to go for an ultrasound. Ultrasound. Will X-ray diagnose these stones? Because calcium content in the stone is very less. Unless the stone has got calcium. Renal stones can be diagnosed with an X-ray because 80% are a calcium stone. But here we have cholesterol stones or bilirubin stones, which are not radio opaque, the radiolucent. So we'll have to go for an ultrasound. Ultrasound diagnoses the stones as well as ultrasound diagnoses. Does the ultrasound diagnose chronic cholecystitis? Yes. Because this can be recurrent cholecystitis. Chronic cholecystitis में क्या मिलेगा अपने को? Thickening of the gallbladder wall is more. That is what, again, not for the exam sake but for your practical importance. Size also it can be reduced. Do we have any stones which has a medical management? Cholesterol stones has got medical management. What do we do? UD-Liv वगैरह देता ना? Ursodeoxycholic acid, UDCA. We can also give cholesterol lowering drugs that can help. If it is bilirubin wala stones, or if it isn't, what are the complications because of the stone? One thing is cholecystitis. The other thing, yes, this can obstruct the common bile duct, can give rise to obstructive type of jaundice. So these stones need to be removed. Which are the patients in which the bilirubin stones will be more common? One thing is cholesterol stones. That is what is common. More common in which people? There is fat female fertile 40. You know that gallbladder का? F is more common in females, more common in the fertile period, more common in obesity, more common during the 40 years of an age. Is more common for those who are doing irregular उपवास, more common. का उपवास करतात का? Because those who are doing उपवासा, त्याच्यामध्ये super saturation of the bile is more common. Because see what happens, liver is producing bile 24 hours. It is stored in the gallbladder and it is released whenever we have food. No. It is stored in the gallbladder. It is getting concentrated in the gallbladder, and it is released in the duodenum whenever we have food and whenever the food comes in the duodenum. With the help of an enzyme called cholecystokinin, is an enzyme that is getting released. So those who are on irregular dietary habits, in which bile stays in the gallbladder for longer time, so there is a super saturation of the bile, and that gives rise to more stone formation. Because of that, maybe it is more common in the female. So there is also estrogen role in it. Estrogen role in it, because that is a reproductive age group, it is more common. What do we? Let's say patient comes to you with some dull aching pain here. We are having an ultrasound. There is a stone 3 by 3 centimeter in the gallbladder. What? It is not producing any acute pain. What will you do? Nothing. Smaller is the stone, more is the risk of blocking the common bile duct. So of course we need to, the urgent intervention may not be required, but we will have to observe it. Or if the patient has got multiple small stones, then preferably the gallbladder need to be. Will you remove only the stone, keeping the gallbladder? We will do cholecystectomy directly. Then what will happen to the cholecystic? The patient who is having gallbladder removed, will he have to do some dietary changes or something like that? Because in this situation what will happen, bile will be released into the duodenum continuously without getting stored. The patient should be having small frequent meals, less fatty food. Patient may also experience some diarrhea because of bile is released into the small intestine more. Bile is more strong, alkaline in chemical in nature, so patient can have biliary diarrheas. More common. Amount of bile released in the duodenum will be more than normal because it is not getting saturated. The volume of bile is going to be more. So patient may experience some bowel changes, but as such doesn't make much difference. Preferably, patient should be advised to have a small frequent meal than having big fatty meal. Less on the fat. So this is what we can do as an investigation as well as management for a right hypochondriac pain. It can also be the liver abscess, but sharp pain will be dull aching pain again. Amoebic liver abscess, it can be a possibility. Very commonly, light lower lobe pneumonia, right? The patient will have symptoms which is of high grade fever, cough, and it can be also right lower lobe pneumonia here. Right lower lobe pneumonia, right? Very commonly, the patient who is having dull aching pain in the hypochondria or may not be having any pain, but there is a constant fever which is not responding to any antibiotics. Very commonly, patient has got a bacterial abscesses in the liver, silent liver abscesses, bacterial, not amoebic liver abscess, bacterial abscess. Because this is what is the very common site of and silent abscesses which are there. So, some patient who is having on and off fevers in last so many days, something called the PUO, pyrexia of unknown origin. Look about the silent sitting abscesses which are there in the liver. Right lower lobe pneumonia, yes, again theoretical. But the symptoms along with that will be respiratory symptoms. High grade fever, cough, breathlessness and all those things. Again, sharp pain will not be there. Empyema thoracis will be heaviness in the lower chest rather than hypochondrium. Will be dull aching pain. That can be a possibility. Sharp pain will be there when amoebic liver abscess ruptures into the pleura. Then it can be a sharp pain which is there. Very common because amoebic liver abscess most common site is right lobe of the liver, the huge abscess. This can rupture into pleura. That can give rise to a sharp pain. Maybe a known case of amoebic liver abscess has ruptured. But usually common causes are the gallbladder causes, as well as some of the liver causes. Dull aching pain in case of hepatitis, and sharp shooting pain can be because of gallbladder or now choledocholithiasis need to be operated urgently. Yeah, yes. retrograde cholangiopancreatography, what is that? ERCP and all those things they do. And this can also give rise to pancreatitis. Peptic ulcer, थोड़ा सा epigastric or maybe upper umbilical region में देना. Because stomach lies here. Let's say, for example, this is what is stomach here. So lesser curvature is more common as in gastric ulcer, and duodenum is coming more of the upper umbilical region. More of the upper umbilical region. So the most common site of gastric ulcer is lesser curvature, and duodenal ulcer is first, because second part मध्ये ही duct open होते ना. This has got alkaline juices in nature, because whatever more acid which is there in the stomach will be neutralized by the second part. So most common site is in first part. So it is an upper umbilical region or lower epigastric region and epigastric region. So the patient has got epigastric pain, a sharp shooting pain. We can have gastric. All this related to stomach. All those will be related. Let's say we have epigastric. It can be in hyperacidity. The patient has got only burning pain. It can be burning pain, right? GERD will be pain which is coming into the neck. And this will be coming in the esophagus, right? Then it's going to give rise to up chest as well as coming in the neck. So hyperacidity. If the patient has got only burning pain, if it is an throbbing pain, throbbing pain, or it can be not burning, but it can be pain after exercise in the epigastric region. It can be inferior wall MI. It can also be inferior wall MI. So that is what should be ruled out rather. Unstable angina or inferior wall angina, inferior wall MI should be ruled out. Now, how will you differentiate gastric pain from the cardiac pain in case of an epigastric pain? Cardiac pain will be related to exercise. Cardiac pain should have the risk factors. Patient should be having diabetes, blood pressure for many years, especially, and this will be related to exercise. Epigastric pain, which is increasing on stooping forward. पुढे वाकलो तर जास्त जळजळ होतं. Can also be again hyperacidity or GERD. Can be GERD. If patient also has got, along with that, patient can be having hematemesis. Then patient can having gastric ulcer. Gastric ulcer. Or patient can be having melena. Can be having duodenal ulcer. So this is the same patient who is having chronic hyperacidity, maybe obese, maybe irregular dietary habit, maybe alcoholic, maybe tobacco chewer for so many years. Patient says maybe an addiction to antacids is also common cause of duodenal ulcers. Ka? Addiction to antacids giving rise to more duodenal ulcers. Rebound increase in the acid production. There is a rebound increase in the acid production because alkaline nature of juices in the stomach produces more acid. The patient who is dependent on antacid, baseline acid production goes up, and that can be because of that no ENO has cured acidity till now, and because of that these antacids is a very big brand because no acidity has been cured by it. In fact, it has been increased, but temporary relief may be there. So any patient who is going to have an epigastric pain, first investigation of choice should be, if it is having a chronic problem, a one day problem is we give an antacids and we just wait, or we give PPIs, proton pump inhibitors for 14 days and then we can. But the patient having persistent pain, patient has a history of hematemesis, then go for OGD-scopy. We should subject the patient for esophagogastroduodenoscopy. This not only localizes the site of problem, we can also take a biopsy so that we can have an idea about what exactly can be the problem. And maybe we can go for chronic hyperacidity, we can also go for H. pylori regimen. H. pylori regimen. So epigastric is the site of stomach problems. Can also be pancreatitis, right? Pancreatitis can also be because pancreas location is again here. Can also be pancreatitis. Isn't again sharp pain in the lower part of the epigastric region. Along with that, what can be the associated findings? Can be backache. That is also because of the radiates to the back because of the position, location of the pancreas. Azun, what can be the associated findings? Patient, no, clinically. Patient, most important thing will be consciousness. Patient can be subconscious or consciousness will be subnormal. Why? Because when the amylase level goes up, that can start damaging the organs. Patient has got history of alcohol, acute alcohol consumption, or maybe history of gallstone, sorry. Usually these are the young patients. And also, what is that? Cooling sign. And there is a bluish discoloration of the, and also Grey Turner sign is an umbilicus wala sign. So we have two signs. These are the signs because in case of an hemorrhagic pancreatitis, where we have the greyish discoloration of the flanks or bluish discoloration of the flanks, and also around the umbilicus. Around the umbilicus. This is there in case of an hemorrhagic pancreatitis. So these need to be referred in time so that patient can be evaluated properly because this patient can die in no time. Now, why do they die? What exactly can be the reason? Peritonitis. One thing is peritonitis, but is this a bacterial peritonitis? If it is bacterial peritonitis, the chance of septicemia the patient will die. More important problem is because of the enzymes that is released in the blood circulation. Because pancreas is a gland which has got endo and exo both. Now, endocrine part that we all know is insulin and glucagon that goes into blood circulation normally. But pancreas also has got pancreatic juice that is supposed to be released into the duodenum because that is what digestive juices, amylase, lipase and protease. When the pancreas get inflamed, those digestive juices ka enzymes enters into blood circulation because of the inflammatory response, because the vessels are dilated. So because of that we do serum amylase level, right? Serum amylase, also lipase protease are also elevated, but the first thing goes up is an amylase. And what will that amylase do in blood circulation? Amylase का काम क्या है? Work of the amylase is to digest carbohydrates, which is supposed to digest the dietary carbohydrates. Now it is entered to blood circulation. So blood circulation madle carbohydrate will be digested. That means RBCs will be digested. Cells will be digested of all over body. Because of that, the serum amylase ka levels decides about the life fatality. More than 10,000, many both chances come hai. 20,000, very rare. It is reducing. Then it is chances that patient will survive. Because of that, patient goes into ARDS, patient goes into coma, patient goes into, because ultimately all cells of the body starts getting digested. That is what is the problem in case of pancreatitis. Because of that, because the enzymes are entering into blood circulation. Very commonly, it can also be because of pancreatitis, can be because of trauma, traumatic pancreatitis, rollover accidents, rupture of the pancreas. So rupture of the pancreas vessels are open. Because of the rupture, the enzymes are also open and they enter into blood circulation. That can give rise to. So this requires to be referred in time, requires antibiotic, requires monitoring, requires symptomatic management. If patient is ARDS, put on ventilator. Patient is on liver failure, put on kidney failure, dialysis, coma. So we require supportive treatment for this. We also require, what is that, octreotide, somatostatin to reduce the secretions. That how much? Huh? Pancreatic tumor.
So the levels of the enzymes the octreotide is given
to reduce the secretion. Octreotide reduces all hypothalamic pituitary ovarian enzymes it reduces. So it can be pancreas. So think about if it's epigastric, think about stomach as well as pancreas. Think about GERD, think about peptic ulcer, think about, so all those things need to be ruled out. Do we have any guarding and rigidity in this case? But all peptic ulcers have guarding and rigidity? Only if it is perforated. So how do you differentiate perforated peptic ulcer from a non-perforated peptic ulcer? First thing is on examination. In non-perforated peptic ulcer, patient will have tenderness only epigastric region. In case of perforated, all over birth. There will also be guarding and rigidity because now there is a chemical peritonitis getting settled up. That high concentrated acid is going to be inflammatory response in the peritoneum. So patient initially patient has got epigastric pain. Now patient complaining about pain all over body. Think about perforated pain. Investigation required for this to rule out perforated peptic ulcer is standing X-ray. X-ray of the abdomen standing. What will you find? We find a gas under diaphragm. A black shadow which is there under the diaphragm. Gas under the diaphragm. Where is the gas coming from? Stomach or perforated duodenum. Perforated duodenum. So right hypochondrium is over. Epigastric is over. Left hypochondrium. What can be the common cause? What is the organ we have here? Spleen. So acute pain in the left. Acute pain and chronic pain. Acute pain can be because of rupture of the spleen is the commonest organ to get ruptured and infarct or rupture, splenic infarct. Patient who is having road traffic accident complaining about left hypochondriac pain and is hypotension shock like condition is rupture because spleen has got the largest capillary network and also we have less smooth muscles in the spleen, so it doesn't contract. So when the spleen ruptures, it bleeds very heavily. So think about splenic infarct, splenic rupture. What do we do? Can we repair the spleen? Remove. We repair splenomegaly. Splenectomy. Emergency splenectomy. Then we have right and left lumbar. Right and left lumbar. Now what is the organ we have here? It's a kidney. So the patient is going to have a flanks pain. Typically, this is what is a common gesture patient always does in case of renal stones. The stone in the kidney, patient is going to have lumbar pain. There is something called the renal angle tenderness. 12th rib and the lumbocostal muscle ka the angle. Renal angle. The patient complaining about lumbar pain always have the history about urine symptoms. Like, do we have any frequency, urgency, hematuria? Frequency, urgency and hematuria. And investigation asked for is TOB again. It can also be and chronic pain which is giving rise to lumbar pain and hydronephrosis. But in acute pain we have renal stones. These are called hematuria. Pyelonephritis gives rise to pain. Pyelonephritis is a bacterial infection of the pelvic ileal system. Pyelonephritis. So everything related to kidney we think about. Pyelonephritis we can have a fever also along with. And hematuria. Chills and rigors, right? Very commonly chills because this is a bacterial gram-negative infection. Common investigation asked for is again we can diagnose in an X-ray because 80% stones are calcium stones. The rest of the 20% are cystine stones and xanthine stones and phosphate stones. 4 types of stones. Cystine, xanthine are very rare. Phosphate stones. First common is in calcium stones. Then we have phosphate stones. Triple phosphate stone, ammonium phosphate, a magnesium phosphate and calcium phosphate. Triple phosphate stone. Only radio opaque is calcium वाला, बाकी things are not radio opaque. बिकॉज याच्यामध्ये कॅल्शियमचं प्रमाण फक्त 20% असतं, याच्यामध्ये कॅल्शियमचं प्रमाण 89% to 90%. So and third common is xanthine stones, xanthine and cysteine. Xanthine, cysteine only in case of metabolic disorders. Oxalates. Calcium stones are small, maybe multiple in nature. Phosphate stones are very big. Usually, largest stone in the kidney is what? Phosphate stone. Phosphate smooth asta. It takes the shape of the pelvic calcium system. It never blocks the ureter. Staghorn calculus. That is what is called as Staghorn calculus. It's because of the recurrent UTI. ज्यांना पुन्हा पुन्हा UTI होतो, those going to have phosphate stones. So what are you going to suggest for these patients who can have a silent sitting stone, maybe an acute stone, acute less than 1 centimeter? Location is in the kidney, not in the ureter. See, the treatment depends upon the location of the stone within the kidney, with the ureter or bladder, and also the size of the stone. Let's say there is a silent stone sitting in the kidney, in the lower pole, 1 centimeter. What do? We give hydrotherapy, increase the water intake. We also give a lot of Ayurvedic therapies will also work. What is that? A lot of cystone. No. This हा टॉपिक नाहीतरी पेपर साठी नाहीच आहे. आपल्या क्लिनिकल साठी आपण जास्त डिस्कस करतो. पेपर साठी कोणी विचारणार? अक्यूट अब्डोमेन क्वेश्चन आला तर मग एवढं डिटेल नका लिहू, पण खूप मोठा होणार. फक्त क्वाड्रंट काढा, डिफरन्शियल डायग्नोसिस सांगा. राईट याच्यामध्ये असेल तर 1, 2, 3, 4 कॉमन इन्व्हेस्टिगेशन देस. याच्यामध्ये असेल तर कॉमन इन्व्हेस्टिगेशन देस. लाईट लेफ्ट लंबार असेल तर केयूबी किंवा एक्सरे काढा and treat according to the size of the stone or the location of the stone. Less than 1 centimeter असेल तर we can hydrotherapy. 1 to 5 centimeter असेल तर there is one ESWL, what is that? Shock wave lithotripsy. Location वर पण आहे. If it is in the ureter, we will have to remove it, or we can at least put the DJ stent. DJ stent you can at least put. If it is in ureter, whatever is the size, we will have to put the DJ stent. किंवा किडनी मध्ये असेल 1 to 5 centimeter, we can go for shock wave lithotripsy. If it is more than 5 centimeter, it should be operated by PCNL, nephrolithotomy, percutaneous nephrolithotomy.
No patient is being done.
हाँ? नहीं करत? More than 5 centimeter because it's not going to. If it is in the bladder, we can do cystoscopic removal. Cystoscopic removal. Acute pain in the umbilical region. What can be the cause? Acute pain, umbilical region. This can be intestinal obstruction. This can be intestinal obstruction and pancreatitis. It's an intestinal obstruction. What are the associated clinical features?
Vomiting obstruction.
Severe vomiting.
Persistent, I can say bilious vomiting. This is what is very important. That means ominous sign is green color vomiting. Normally, do we have bilious vomiting? Bilious is bile. Bile म्हणजे कुठे रिलीज होत होते? Duodenum. See, what is normal vomiting? Stomach content coming out. That is what is normal vomiting. Can be because of hyperacidity, can be because of undigested food, can be because of poison, can be because of lot of other causes of vomiting. But if the bile is coming in the vomiting, that means it is an ominous sign. Bile could release होता है duodenum. Never ever the situation arises in which small intestine empties into stomach. Because pyloric sphincter is a one way. Pyloric sphincter doesn't allow small intestine food to come out in the. But if there is an obstruction, nothing is going forward, then only it allows the bile to come up in the stomach. So if you have a green color vomiting, bilious, is a very bad sign. That is what then can be case of an intestinal obstruction. Along with that, patient will also have absolute constipation. Not only constipation, but what is absolute constipation? Not even stool, but gases are also not coming out. And patient has got an abdominal distension and signs of dehydration. And what will the type of pain? It is an intermittent pain, continuous pain. Intermittent colicky pain. Why intermittent colicky pain? See, intestines are trying to do what? Overcome the obstruction. So they are contracting intermittently. So patient has got pain-free episodes at least for a few minutes, and again there is an excruciating pain. Initial stage में hyperperistalsis, then it also goes off. So intermittent colicky pain, then the pain reduces, dehydration increases. What complications? Patient goes into dehydration, shock. Patient goes into alkalosis. Why alkalosis? Repeated vomiting, right? So losing more hydrogen ions. Patient goes into alkalosis. Investigation? X-ray of the abdomen. Again, standing. Vomiting one symptom. Persistent vomiting and bilious vomiting. Bilious vomiting. X-ray abdomen standing. What will you find in the X-ray abdomen standing?
Fluid levels.
Air fluid levels. Do we see any air fluid level normally?
No.
There are about 2 to 3 levels are seen, depending upon the dietary intake. आत्ताच जर पाणी घेतलं असेल, फूड घेतलं असेल तर काय पोटात दिसेल नाही एअर फ्लुइड लेवल. Second air fluid level is also seen in the small intestine. So 2 to 3 air fluid level normally is seen. More than 3 is significant. Multiple air fluid levels. आता हे का मिळतात आपल्याला? Because this is seen proximal to the obstruction. And because of intestines are getting coiled up like this, and या coiled up intestine मध्ये there is a food, and food पुढे गेलेलं नाहीये, त्यामुळे काय होईल? Food gets fermented to produce gas. So black is the food, red, blue is the gas. You can see multiple air fluid levels like this. There is more gaseous distension because of fermentation of the food in the intestine. So this is more than 3 air fluid levels. What do we have to do? Refer the patient in time. Don't give antispasmodic or something. Don't even give paracetamol. Give ambulance. If it is not the, give your car, your driver. नहीं डॉक्टर ने 15 मिनट लेट किया ना. Recent thing, my friend's hospital in Nanded, very good friend of mine, very big hospital. Recent real story. The patients came. The doctor was about to come. For 35 to 40 minutes, doctor came down. Doctor examined the patient. Man referred the patient to the higher center because of a complicated one. Baby died over there, and they all blame. Because usually क्या होता? For example, if somebody refers patient to a higher center, the patient could not survive. What is the first statement by them? थोड़ा जल्दी लाते तो अच्छा था. Just for the sake of they want to take, they wanted to show that we could have recovered the patient if we could have received the patient in time. Now, where is the blame gone now? That 35 minutes. The whole havoc. You could have, if you were not there, why you would make us waited like this? So all those things. So refer the patient in time. So refer the patient in time. It can also be strangulation, right? Strangulation, again, it can be in hernia and strangulation and can give rise to intestinal obstruction ultimately. Can give rise to. Intussusception is also type of intestinal obstruction only. There are, see, volvulus is one of the type. Intussusception is the other type. It can also be because of adhesions. There are different causes of intestinal obstruction. Intestinal obstruction. Can it be also paralytic ileus?
Yes.
Give rise to same symptoms? Paralytic ileus is a non-obstructive, as in paralysis of the intestine. Only thing is pain is not there. Atoning is there. Distension will be there, vomiting will be there, the pain is not there. Then diverti कुठले sigmoid colon मधला. Then intussusception. Colon into the colon or maybe intestine into the intestine. Intussusception. सगळ्यामध्ये आपल्याला findings same मिळतील. What is the first thing they supposed to do? They put the Ryle's tube. Aspirate, stomach aspirate. And most important thing is relief of obstruction. Do we have any conservative management? If with intussusception, what do they do? But you have to open it, right? You cannot do conservative management. Intussusception is a special we require. Oh, see, one of the types is in volvulus. Have you heard about volvulus? Colon ka loop is rotating on itself. Usually because of chronic constipation, like the sigmoid colon, the dilated sigmoid colon rotates on itself. Can give rise to intestinal obstruction. That needs to surgical repair.
That is volvulus.
That is volvulus. Volvulus is revolving on the colon revolving. Let's say this is what is the loop. This revolves on itself. So it's getting twisted. Usually the sigmoid colon because of loaded with stool and gets more common in children with chronic constipation. Intussusception is also a common condition in children again when intestines go to the intestine. There is something called as an intussuscipiens is an outer one, intussusceptum is an inner one. It occurs more common in children because they say in that part of the colon or intestine there is no nerve supply. So peristalsis is there in this part and this part. Yeah, part में peristalsis is not there. The patient has got diarrhea attack. Diarrhea मध्ये we have hyperperistalsis. So intestines are having hyperperistalsis here and here there is no peristalsis. So this part of the colon, intestine enters into this intestine. हा contracted segment है, हा dilated है. त्याच्यामध्ये घुसतो. Just like when you open the digital camera का lens, so one lens comes out of the other, similarly it goes inside. That is, and that can give rise to obstruction. In more common in children because it's a congenital condition in which we have absent.
Most of the time they respond to antispasm.
Agnes only they respond. There is also hydrotherapy in that. What do? From per rectum they push water. And it will. There's what is that called? Water wash, or maybe some treatment. There's somebody who has done it. And there's a special type of stool. They will have red currant sputum, red currant jelly stool, something like that. On the fingertip, that's what we can find in that particular case. But usually more common in children, no other. And usually most common cause of intestinal obstruction is adhesions, previous operative surgical adhesions. That can be the common cause. Or maybe in hernia, if it is an obstructed hernia, that can be the common cause. Tuberculosis, acute pain that is also can be because of the fibrosis of the intestinal tuberculosis. The lumen can get. त्याच्यामध्ये subacute obstruction जास्त होणार. Acute subacute होतं. Yeah, it can be embolus going into the mesenteric artery and that can ischemic enterocolitis. Ischemic enterocolitis. By and large, all of them requires exploratory laparotomy and worm obstruction. Yes, At today's age, it's becoming less common because of more hygienic conditions. You must have seen that video where I got some noodles are coming out. There's undigested noodles. Somebody said Maggie don't eat. These are all worms. These are all worms. Mesenteric infarcts. Yeah, known cardiac case. Huh? Muscle thrombosis. Very common in the cardiac patient usually. Cardiac patient. So if you're thinking about umbilical pain more, think about small intestines more. Think about small intestines. If the pain which is there in the right and left iliac fossas, I can say we have something special in the right iliac fossa, and that is what is an appendix. So it can be bread and butter of the surgeons, right? What would surgeons have done if there would have been no appendix? And no hernia and hydrocele? No hernia and hydrocele. What would obstetricians have done if there is no cesarean sections? Nothing they have done. So right iliac fossa. Let's discuss some common things in right and left iliac fossa, and then some special things for. What is common thing in both? We have ureter. Let's discuss common for men and women both. So we can have ureteric stone, hydroureter. There's something called a loin to groin pain, right? Loin to groin pain. We also have uncommon dull aching pain can be psoas abscess. But what will the associated finding? Clinical feature. Chronic backache is one because it can be most commonly the tuberculosis of the spine can give rise to this psoas abscess. One common feature is pain which is increased on active flexion of the attitude of the patient. Then because psoas muscle is important flexor of the hip joint. So active flexion gives rise to more pain. Psoas abscess, all theoretical ones. So ureteric causes psoas abscess. For women, think about ophoritis, PID, salpingitis, right? Ectopic, torsion of ovarian cyst. The patient is a woman, think about the other factors also. And for right side, we have something special, that is appendix. Pain, fever and vomiting. McBurney's triad. McBurney's point कुठं असतो? That is 1/3 laterally, 2/3 medially. Sino-umbilical line. Umbilicus to the anterior superior iliac spine. And this is also McBurney's point. We also have McBurney's incision, which is perpendicular to this line at this particular point, 2/3 above, 1/3 below. This is also again 2/3, 1/3. This is McBurney's point. McBurney's incision is this. McBurney's incision. So appendicitis, patient has got triad of symptoms, pain, fever, and vomiting. What will you do to confirm your diagnosis? Do CBC. WBC count has to be raised. Barium, but barium up to the appendix याला already 24 तासापेक्षा थोडं कमी 18 तास लागतील. And what will you find? Can you see appendix normally? Can you see normally appendix can be seen, not seen?
Why USG is not seen?
USG na, barium. USG appendix is not unless it is enlarged and having appendicular mass or appendicular tumor. Then only it can be seen in the ultrasound. So ultrasound is not the way to diagnose appendicitis. CT scan may not be available at the acute episode. Patient comes at 2 o'clock in the night. CT scan may not be available. So barium is mostly a clinical. That's what I'm coming to. And because barium may also normally we see the appendix because appendicular lumen is open and we see a small dead line, a small thin line. Non-visualization of an appendix may be an appendicitis because most common cause of appendicitis is an obstruction of the lumen. obstructive appendicitis ज्याला म्हणतात. There is a ficcolith, there is can be food particle, or then many people say याचे दाणे खाऊ नका आणि याच्या बिया खाऊ नका and all those things. That can be an obstruction, but that doesn't guarantee again barium, because many time in a normal appendix also, because of the small lumen, it may not fill. I mean, you may not be able to see. So again, most important judgment is clinical. The patient has got typical, there is something called rebound tenderness. What is that? When we palpate, that causes pain, but when we remove, causes more pain, because it gives an idea about peritonitis surrounding peritonitis, local peritonitis. So appendicitis can be also be managed medically by giving antibiotics and antispasmodics. As appendix is ruptured, then we will have to operate appendicectomy. But the judgment is according to the WBC count. The WBC count is normal, patient has got a pain, then
Stone. Urinary stone.
it can be ureteric origin, it can, patient also has urine routine microscopy normal. Many times the appendix is there in the mind, dukta hai, and you have 10 times in a day, for 10 days it will start paining here.
Patient has already taken antibiotics.
Recurrent appendix, see, chances of rupture of the appendix is more common in case of a recurrent appendicitis, because first there is an attack, there is a fibrosis occurs, let's say it is not ruptured. Second attack, the fibrotic appendix is more easy to rupture rather than a normal appendix. So patient has got second attack, third attack, usually remove the appendix. Appendicectomy need to be performed during the attack or in between the attack. If it is ruptured, we will have to operate immediately, give an antibiotic umbrella and operate. If it is unruptured, give antibiotic, stabilize the patient and then operate. In between the attack, we will have to operate, because during the attack there is more chance of infection, septicemias and all those things. So, planned surgery usually is better. But if it is ruptured, then we will have to operate at that point, because to prevent that peritonitis to develop. What is special on the left side? Left iliac fossa? So here, there is a sigmoid colon, there is volvulus, there is also diverticulitis, you must have been heard about. So think about bowel history, take the bowel history properly, constipation or maybe in mucus discharge or maybe and lump which is there in the left iliac fossa. Left iliac fossa. So think about these things before. Left iliac fossa, we can have diverticulitis, CA colon, and बाकी सगळे हे नॉर्मली युरेटरचे जे सोया सबसेस युरेटर और हे सगळे विमेन्स मध्ये उफोरायटिस, even orchitis also gives rise to iliac fossa pain because the nerves are coming from there. Orchitis also gives rise to iliac fossa. Strangulated hernia. So the location is the same. Inguinal ligament varti. Strangulated hernia. And lastly, we have hypogastrium. What do we think about? Urinary bladder. It can be cystitis and UTI, bladder stones. In women, we also think about uterus, or maybe in abortions, maybe inevitable abortion. Fine, ठीक है. So here again, take the urine routine microscopic history, take the ultrasound. It can be retained, retention of the acute retention of the urine. Can be having hypogastric pain. Acute retention of the urine. So we will have to think logically depending upon the region of the abdomen, take the proper history, investigate, and then either a medical or surgical management is what can be done. Maybe asked as an LAQ. So याच्यातलंच मोठं डायग्राम काढून इथेच डिफरन्शियल डायग्नोसिस लिहा आणि तेच 2-4 पानं लिहायची त्याची इन्व्हेस्टिगेशन अँड मॅनेजमेंट. ओके, चला नेक्स्ट लेक्चरला रिमेनिंग अल्सर वगैरे घेऊया जे सर्जरीचे आहेत आणि फार्मॅक चालू करूया. ते संपल्यानंतर पिडियाट्रिक चालू करूया. ठीक आहे. ठीक आहे.